Good afternoon, everybody. Thank you for joining us here today. I know that my competition is Rabbi Bender, so it's a little bit of a tough competition. So they asked me to speak a little bit about dementia, and we have a little bit of a forum here. We have Mr. Gelman, we have Mrs. Friedman. All of us sort of bring different expertise to the table. I'm a practicing neurologist, so I sort of have that perspective, and Mrs. Friedman has some personal experience with dementia, and Mr. Gelman as well has some personal experiences with certain types of dementias. So just to sort of open it up, just to keep things very informal, you can scream out questions, you can do whatever you want, and we'll make the best of it. We can handle it. So just a little bit about dementia. So dementia is sort of a hodgepodge of disease, okay? So there are many different types of dementia. Dementia by itself just really means memory loss. That's all dementia means. Now, memory loss can happen because of a bunch of different reasons, okay? So there's the dementia that we're all familiar with, which is Alzheimer's, but believe it or not, there's a lot of other types of dementia that are not Alzheimer's and that can actually be treated very, very differently from Alzheimer's. So Alzheimer's patients typically come in and they're treated one way, they're treated with certain medications, but other types of dementia are treated very differently. So just in terms of the demographics, dementia in itself is a huge mental health problem. It's a huge medical concern. It has huge financial implications for society, really. There are about 5 million people with dementia, and that number increases exponentially every year. So we're getting much better. I'm sorry, go ahead.
I read that women, all dementia patients, 2/3 of them are women. And I'm wondering if that's really an accurate statistic, because women live longer than men. Therefore, as they get older, you can have more dementia patients.
Yeah, so I think that's a fairly good assessment. I think that there are some other factors that come into play. Women are sort of protected a little bit by estrogen and progesterone, and then once that falls away during menopause and after menopause, then they sort of rapidly catch up to the men. And it's very similar to coronary artery disease and stroke risk. Has a tremendous overlap with that. But just in terms of the numbers of dementia patients, 5 million, and as we live longer, the single biggest risk factor for dementia is age, right? That's something we all know. So we're getting very good at treating other types of illnesses, and as we do that, we have to deal with sort of the byproduct of that, which is dementia. So just in terms of, if we're to pick sort of Alzheimer's dementia in isolation, so, nobody really knows what causes Alzheimer's. There are a lot of theories about plaques and tangles and things called amyloid and tau. And these are basically different types of protein that accumulate in the brain. Nobody knows if that accumulation of protein causes the dementia, or if the dementia and Alzheimer's causes the accumulation of protein, right? So the cause and effect has not been teased out yet. A lot of the medications that we use for Alzheimer's dementia have to do with increasing the amount of neurotransmitters within the brain. So the medications like Aricept, Namenda, these are all medicines that are used to increase the amount of acetylcholine in the brain. And in doing so, they delay the progression of disease. So this is something that's also very important when we're dealing with Alzheimer's dementia. And it's a conversation I have several times a day, which is where you have to explain to patients that when you've made the diagnosis of Alzheimer's disease, and we can discuss how that's made in a minute, but when you make that diagnosis of Alzheimer's disease, the treatment does not reverse the dementia. The treatment delays the progression of the dementia. So if you look at it as sort of a slope, when we first see that patient, we don't know their degree of decline. We don't know how rapidly they're going to decline in terms of their Alzheimer's dementia. Okay, we'll only know that as time goes on, where we can sort of plot out where they are. Some patients will have mild cognitive impairment, which is thought to be the first stage of Alzheimer's, and they'll remain like that for 20 years, and they'll, die of old age. But other people progress much more rapidly, and by that I mean over the course of a year, and even sooner in many patients. So one of the things, one of the questions that I get asked very frequently is, do I have Alzheimer's? I forgot my keys, I forgot where I parked, I left the stove on. Do I have Alzheimer's? Am I going to get Alzheimer's? My mother had Alzheimer's, my father had Alzheimer's. Am I at risk for Alzheimer's? So it's always important to sort of look at the context in which the question is asked. So there is a tremendous difference to me as a neurologist when I see a patient walking in, sort of holding their, Louis Vuitton handbag, saying, "Gee, I forgot my keys," versus a patient coming in surrounded by a family who has concerns. Okay, and in fact, there's a huge difference between the two. So a patient who comes in and they describe one isolated event, they forgot their keys or they keep forgetting these. I don't take that as seriously. I don't consider that Alzheimer's. I consider that sort of mild cognitive impairment or even just benign aging. I don't think that that's anything. But that's very different from the patient himself being in the office having no idea why he's there, and he's there with his children and other family members, and they say, well, he's forgetting where he is, and he's not able to dress himself, and he's just more out of it. He's sort of withdrawn. He's not as outgoing as he was. He doesn't interact with his friends as much as he was. In our community, he's not going to shul anymore. He used to go to a shiur. He's not going to a shiur anymore. That, to me, is much more concerning. Now, in order to sort of make the formal diagnosis of Alzheimer's, you have to pick more than one, what we call sphere of cognition, right? So it's more than just memory. We always think about memory because memory is something that we can all relate to, and it's very easy to put your finger on memory loss. But if you think about what it is that makes us who we are, it's things like memory, it's things like language, it's executive functioning, right? All these things comprise who we are. So if you look at sort of social disinhibition, people saying inappropriate things publicly, that can sometimes be a sign not of Alzheimer's, but that could be a sign of different types of dementia, something called frontotemporal dementia. If you look at patients that have memory loss, but they also have hallucinations, that could be a sign of Lewy body dementia. Okay, so these are different diseases. Not everything is Alzheimer's. If you look at a patient that has multiple strokes and they keep declining cognitively and in their ability to ambulate, those patients have vascular dementia. They don't have Alzheimer's dementia, and the treatment there is totally different. So it's always important to keep these type of things in mind. Not every person with memory loss has dementia. If they have memory loss, but also they're disinhibited, and also they have trouble in social situations. They're saying inappropriate things. They have trouble with their finances. They have trouble doing calculations. They have trouble managing their finances. These type of things. That goes more in line with the diagnosis of Alzheimer's dementia. Okay, and keep in mind also there is no test. It's not like you get your blood drawn and we get a lab result and here it's positive and boom, you have Alzheimer's dementia. It's a clinical diagnosis. So clinicians can sometimes disagree about what is Alzheimer's and what isn't Alzheimer's. The only absolute definition is to do an autopsy, which obviously is not very practical in the real world. But that's where a lot of the knowledge that we have comes from.
CAT scans?
So CAT scans in patients with dementia often show atrophy. So what they show is that the cerebral cortex, which is sort of the higher processing area of the brain, sort of the gray matter that surrounds the brain, that area is atrophied, meaning that it's shrunken. And that is something that happens normally with age. As we age, we lose millions of neurons each year. Some people even lose more than that, depending on some of their other activities and whether they have other risk factors, like diabetics, hypertensives, people that smoke. These people lose more brain cells annually than other people do. One of the things that is now being done is PET scans, right? So PET scans are when we inject a certain radioactive contrast, and we look at the parts of the brain that take up that contrast. So glucose is metabolized by the brain. So as we take up that radioactive contrast, we're able to see the parts of the brain that light up. Okay? So patients with Alzheimer's will show a diffuse decrease in uptake, as opposed to patients with frontotemporal dementia, where, as you would suspect, their frontal lobes and their temporal lobes show a decrease in uptake. And that's one of the ways that you distinguish the two. There are other entities, and I think we're going to hear about normal pressure hydrocephalus. So normal pressure hydrocephalus is a clinical syndrome, really, of... I'm sorry, go ahead.
Would you suggest to someone who is thinking about whether he or she or family members has dementia to go through a CAT scan?
So I always get an MRI on every patient with memory loss because I personally have been burned by not doing so. So I have had patients come in with memory loss that I would swear was either they're depressed, something called pseudo-dementia, right, which is where depression looks like dementia, looks like Alzheimer's. And I've sent them for MRIs, and I've found huge subdural hematomas. Okay, so a subdural hematoma is bleeding around the brain. It's not bleeding in the brain, but around the brain, compressing on the brain. Okay, and that can cause all sorts of problems. Problems with language, aphasia, weakness, hemiparesis. These are all things that can be caused by subdural hematomas. So you really don't want to miss that because it's absolutely treatable and it's absolutely reversible. So that's something that you do not want to miss. So I image all patients with memory loss or memory decline. Okay, that's sort of, and I think that most neurologists do that, and I think it's in national guidelines.
Years ago, when my brother was diagnosed, they said that Alzheimer's was a disease. And they said he had no oxygen going to the brain. That's how they did diagnose him.
Right. I mean, so no oxygen going to the brain is a sign of brain death, to be entirely honest with you. So I think they were probably talking about a decrease in the amount of oxygen. Right. And that is something that Alzheimer's patients are believed to have, and that is why patients that have diabetes and hypertension and coronary artery disease are at a greater risk for developing Alzheimer's because of their atherosclerotic arteries to the brain, because of their hardening of the arteries. They get less oxygen to their brain, and that is believed to trigger Alzheimer's disease. Okay, but just getting back briefly to normal pressure hydrocephalus, because Mr. Gelman is going to talk about that very briefly. So it is a clinical syndrome of patients who have memory loss, they have dementia, and they have urinary incontinence, and they also have hydrocephalus. Hydrocephalus literally means water on the brain, but that's really a very lay interpretation of what it is. Hydrocephalus means that there's a problem clearing the cerebrospinal fluid from the brain. So the cerebrospinal fluid surrounds the brain, and it acts to give the brain somewhat of buoyancy, so it sort of floats around the brain and the spinal cord. And if there's a problem with absorption or an overproduction of this fluid, you get hydrocephalus. And that is one of the reversible causes of dementia. So I don't know if you want to speak for a few minutes. You want me to speak about it?
Are you taking questions?
I am taking questions, sure.
I read somewhere a bunch of years ago that the loss of the sense of smell is indicative of. Now, I lost my sense of smell about 15 years ago, and I asked my EMT about it, and he said, about the connection with Alzheimer's, he said it's nonsense.
Yeah.
So,
well,
because I was really, really worried.
Right. So I do see patients probably about twice a year that come in and they say I can no longer smell things, and I've never found a cause for it. It is in the literature that the loss of smell is the first sign of both Parkinson's and Alzheimer's. That does exist in the literature, but obviously this was 20 years ago. I think that that ship has sailed. So I wouldn't necessarily look back and think.
But is it a current theory that everybody ascribes to that?
Yes.
That
it's called anosmia, and it is believed to be a precursor to neurodegenerative disease. And the reason for that is. The reason everybody's smelling each other. The reason for that is that the smell, the olfactory bulbs, these smell nerves, are one of a handful of nerves in the body that regenerate. So if you think about it, if you smell something that's very toxic, if you smell bleach, you're actually killing those nerve cells, and they regenerate very rapidly. So it is believed that that is the first sign of cells not being able to regenerate, is that loss of regain in function of smell.
But it doesn't necessarily have to be.
It doesn't necessarily have to be. No, there is a correlation. There is not a cause and effect, right? So the two are related, but not in effect to each other.
I have a relative who, over a period of time, has difficulty in completing sentences because that person forgets the proper word to it. Is that something to be concerned with?
Yeah. So so obviously it's something to be concerned about, right? But without getting into sort of the whole hodgepodge of dementias, because there are many different types of reasons for memory loss. And again, I don't know your family member. I don't know if they may have had a stroke that affected their language. There is an entity called primary progressive aphasia, PPA, which is a type of degenerative disorder. And it is sort of punctuated by the inability to get words out. It's called aphasia. It's a disorder of language.
That's not what happens. It's the middle of the sentence, and they know, for example, they say something about light bulb, and they don't have it. They can't find a word for light bulb.
Yeah.
Something like that.
Right. So again, that is an aphasia. That is an aphasia. And using a different word for light bulb would be a type of paraphasic error. Okay. Where was I? The other thing that's sort of important, in particular, in let me know when you want me to stop. I can turn this off at any moment. 3 minutes. Okay. It's always important to know that in an older person, whenever they have an acute change, meaning that there's a change that happened all of a sudden, that they be evaluated for that. Because in an older person with dementia who already has a compromised brain, meaning their brain is already not functioning to its maximum ability, anything, and by anything I mean a small urinary tract infection, can tip them over the edge and make them extremely confused. And this is something that's very reversible. Okay, so it could be a little bit tricky sometimes. Because you're not sure, gee, is their dementia just getting worse? Or, the doctor started a new medicine, so maybe they're a little tired because of that. They were a little agitated, so the doctor added Seroquel. So what's going on here? So it's always important to err on the side of caution and to have those patients tested to see whether or not there's a metabolic derangement, whether or not there's a small infection brewing, because that's something that's very reversible. So always keep that in the back of your head.
Do you feel that every Alzheimer's patient, let's say they're in their 80s, has to see a neurologist? If they already know the diagnosis and they've had it for 15, 20 years? Or
I mean, as a neurologist, I think every patient with a neurologic problem should see a neurologist. Now, I realize that in the community, these patients are taken care of by...
let's say they had gone already in the past. They've been through programs and they're on the regimen of medication.
Yeah, I mean, it depends if there's been any change. There are a lot of newer medications that are coming out, and these medications are not always on the internist's radar. Okay, I mean, I know about medicines and things that I can assure you the internists don't. The same way the internists know about blood pressure medication and, hyperlipidemia, and they know about that much more than I do. But since this is what I deal with, I know about this sooner than they do. So I don't want to say sort of vast generalizations, but I think it is important to get a neurologic opinion. That doesn't mean you need to see the neurologist every 2 weeks. That means once a year, hi, what's doing, anything changing, anything new, that kind of thing.
The medications that are coming out, do they reverse, or it's just to sustain?
Right. So this is something that we spoke about earlier. The medicines that exist now do not reverse Alzheimer's dementia. They delay the progression of Alzheimer's dementia, and that's very important.
At that point, where that medication is doing nothing,
Yes.
Will the new medications reverse?
So to be entirely honest with you, I don't think that is what is currently in the works. What is in the works now are medications that look at targeting tau and amyloid, which we spoke about briefly, are the two types of protein that accumulate within the brain. When those proteins accumulate in young patients with mild symptoms, the goal of these medications is to prevent the progression from that point. That is the goal. Okay. Unfortunately, the patient who's 95, end-stage dementia, is not really the target of a lot of these newer medications.
I was wondering, if you have an MRI on a patient, a year later, would you know the progression of the disease a year later if you take an MRI a year later? Would you know how quickly?
Yeah. So there is a lag. With a different type. There is sometimes a lag in terms of the MRI. The best assessment are neurocognitive testing and the clinical exam. Okay, so if the patient was able to sort of articulate where they were today, and then 6 months later they're more confused, then that to me indicates that there's a delay. I don't usually get serial MRIs on patients. It's just a waste of time. Just very quickly, I want to turn it over to Mrs. Friedman.
3 quick questions.
Only 3.
Supplements,
Yeah.
vitamin supplements and what that. What's
Yeah.
your feeling on that for patients with Alzheimer's?
In my opinion, vitamin supplements have not been shown to be beneficial. The only things that have been shown to be beneficial are a Mediterranean diet, exercise, sleep, and being, so having 8 hours of sleep, believe it or not, is correlated with less incidence of Alzheimer's dementia.
When you're younger or when someone's already diagnosed?
So this is usually when you're younger or when you're right at that mild cognitive impairment stage. Okay?
And would you say the same thing, let's say, to people who have parents that have Alzheimer's as a means of warding it off?
I would advise that. Yeah, I mean, I think that it's important for a whole host of reasons to adhere to a strict diet and to take care of yourself. I mean, Alzheimer's aside, you're going to live longer just because of the benefit for cerebrovascular, coronary artery disease, warding off cancers. I mean, there's a whole host of benefits to being on very particular types of diet and taking care of yourself in terms of aerobic exercise and things like that.
Would you recommend nutritional supplements to children of parents with
I personally would not recommend that, and I don't think there's any evidence to suggest that that's beneficial.
Okay, one last question. Aluminum pans.
Aluminum pans.
Baking with aluminum foil. What's your any correlation?
I don't think that there's any evidence. Let me tell you something. If aluminum pans caused cancer, that would be in the front page, dementia, or cancer, or heart disease, or any other problem. That would be in the front page of the New England Journal and the front page of the New York Times, and nobody would dispute it. So I think a lot of, I have patients all the time that come to me with these different things, and a lot of these people are being taken advantage of by people that are trying to sell them snake oil. In fact, literally snake oil in the case of MS, which is a whole separate conversation. But and there's no evidence to suggest that this is beneficial in any way. If there was, then trust me, you would know about it because it would be all over the place.
Well, it is all over the place. I mean, the question is whether there's any substantial backup for it.
To my knowledge, there's no evidence. I just want to let Mrs. Friedman talk because she has a lot to say, but I'm here all week.
Okay. Hi, my name's Hennie Friedman. I'm a registered nurse, but my experience is not about my nursing. It's about my husband, who was diagnosed in 2008 with Lewy body dementia. That was 8 years ago, and I would say he was definitely sick for at least the last 10 years, and I've been his primary caretaker. So I've learned a lot over the years, and the first thing that we were talking about is whether you feel it's really important to get a right diagnosis, and I can tell you that although a lot of people disagree with me, and I actually have a friend who's in a stage of dementia, and she refuses to go and get a diagnosis, I feel very, very strongly about getting a proper diagnosis. As Dr. Salamon said, not only is it true that different drugs work for different types of dementia. It's also true that with the wrong drugs, you could make someone very, very sick, which is basically what happened to my husband, because I found out that just like in orthopedics, you go to one doctor for your thumb and another one for your pinky, in neurology, I realized that I should have been looking to go to a neurologist who deals with memory problems. And initially, everywhere I went, they told me that was what my husband had. We went for a sleep apnea test. They said, oh yeah, your husband has sleep apnea. We went to a person who specialized in seizures. This one was interesting, and they said your husband definitely has seizures. So what happened was I was dancing for joy. I thought, well, that's not bad, because I already thought for sure it's worse than that. And we started my husband on a regimen of seizure medications, and he kept getting worse and worse and worse. And I kept calling back this doctor, who was a very big doctor in Manhattan, and finally he just got so sick of me, he said, okay, so cut it back. As a nurse, I know you have to do that really slowly, but obviously I didn't do it slowly enough, and my husband had a vicious grand mal seizure on the way to work on a city bus. Now, I've seen many neurologists, and I learned from one of them that it's actually possible that if you never had a seizure in your life, and you take tons of seizure meds and then you go off them, you can actually have a seizure. It is true that in various stages of dementia, people do have seizures as the disease progresses, but at that time, my husband wasn't having seizures except for this. And what happened was, we didn't have a diagnosis, but he ended up in a hospital where they were pumping him with Ativan. Ativan is something similar to Valium, which usually works to calm down seizures. Now, since my husband has a diagnosis, which I never heard of in my life until 10 years ago, Lewy body dementia is the second most common dementia after Alzheimer's, and somehow people really never heard of it. I think a lot of times it's mistaken with Parkinson's, because there are Parkinson's-like symptoms when you have Lewy body dementia, but what happened was Ativan was something that caused what's called a paradoxical effect, meaning the more Ativan they gave him, the crazier he became. So he was completely and totally out of his mind, and we ended up in Columbia Presbyterian in the ICU, in the neurology ICU. So at that point, I went over to one of the nurses and I said, I've been trying to reach this doctor, some big guy at Columbia, and he doesn't want to take patients. How can I get to him? I need a diagnosis. I don't know what's going on. And she said, just ask for for so-and-so, this particular doctor, to come and give you just what's it called? A consult. So he did. And I said to him, listen, I'm going nuts. I have been running around for 2 years, and I still don't know what's wrong with my husband. My husband was well-dressed. He had a great sense of humor. He was very intelligent. Everywhere he went, people said, I don't really know what you're talking about. At a certain point, I was starting to think maybe I'm losing my mind, because how come no one else is seeing what I'm seeing? To me, it was so apparent. Always trust in yourself. If it's your mother or your sibling or your spouse, you know what you're talking about. You know what's normal for that person. And when you see something that's frightening, you're not making it up. It's for real, and you should trust in yourself to follow on that instinct. And he said to me, give me a week and I will give you clarity. At that point, he did the MRI, he did the CAT scan, he did a PET scan, which targets the activity of the brain, and he did spinal fluid studies, all of these things. Initially, he told us Alzheimer's, but when all the tests came back, he explained that it's a different protein blocking up the brain. It's Lewy body dementia. And at that point, I was like, okay, let me learn about this. I have no clue what this is, but we're going to deal with it. So I feel very strongly, maybe with a much older person who doesn't want to deal with hearing it, you need to respect other person's opinions, but as a caretaker, I think it's really important to kind of know what you're up against, and also you still have that little small chance that you've got something curable, which is awesome. That's the first thing you want to do. I went to my regular doctor to, for the, what's it called? the hydrocephalus.
Oh, hydrocephalus.
You know, to rule that out, because I said, oh, that'll be a good one. Like a lot of things that I read about, I'll take that one, but just didn't work out. So I do feel it's very, very important. And I do also feel that sleep somehow is strongly connected. My husband actually was giving a Dafyomi shir at 5:30 in the morning and waking up at 3:30 in the morning. And for 10 years he did this, and he had very, very little sleep. So at first I said, oh, he's not sleeping. You know, that's why he's nuts. He's really okay. But I sometimes I wonder if it didn't aggravate it. I'm really happy he gave the shir, but I do think that there's some sort of connection with sleeping. I also was advised, once my husband became stable and we got out of the ICU and we went through a lot of things, certain neurologists advised against exercise because they thought he'll fall, he'll kill himself, but I just bought a bike and let him go because he was heartbroken that he couldn't drive, and it was very frustrating, and I wanted him to have the ability, and he was fantastic. Like, he'd run 45 minutes on the treadmill, and he was very, very active. See, when it's a younger person, you're dealing with the fact that somebody is physically strong, but very confused, and you deal very differently than if the person is very, very weak and needs a lot of physical attention. So, my husband is now 66, and he's been sick for at least 10 years, I would say. I also feel very, very strongly, I can't stand when people lump it all together. Sometimes you go and somebody tells you, it's dementia, what do you care, it's all the same. It's not true. And no matter how bad things get, you need to be proactive and stay positive and tell yourself that you can make it better. And after quite a few years, my husband was very, very psychotic. It was just a terrible, terrible time for all of us. And we kept thinking, like, okay, this is it. What are we supposed to do about it? And we kept trying different medications, and nothing was working. We're almost at our wit's end, and we kept saying, no, we're going to stay positive. You can look up and speak to as many doctors as you want, and in the end, 2 different doctors suggested a medication called Clozaril, which they don't like to use because it has a lot of side effects and it requires blood work. And basically, that medication saved my life because I for sure would have had a nervous breakdown. And it was like unbelievable. What happened was my husband hadn't slept for 3 days and 3 nights, and he was completely psychotic. Nobody could handle him. And I told my kids, we're going to the hospital. There needs to be 2 of us 24 hours a day. And, we're going to see what happens. And after a few days on the Clozaril, he actually started to sleep a few hours, and they said, okay, go home, it'll get better and better. It got so unbelievably good. Even though a person is very forgetful, doesn't mean that they need to be agitated, that they need to be upset, that they need to be angry. Today we have so many medications to control that, and here I am 10 years into the illness, and I can tell you that my husband is the sweetest, most comfortable type of person that you can imagine. Like, people are very surprised. Even though, it's been a long time and he's very, very limited and he's very, very sick at this point, our goal is that he should be comfortable and he should be happy. And the fact is that we went together. Some people want to keep things from their spouses. I'm very into honesty. We went together, we got the diagnosis together, we talked about it, we told all our children, and we planned. And he told me, I'm really bad with pain, so just keep me out of pain as much as you can, and I'll deal with everything else. Give me a few toys, I'll be happy, I'll be good. It was crazy, but that's really how it's been. So no matter how depressing, no matter how much the person is aggravating you, you can always have hope that there is something you can do to make it better. I'm not saying you're going to cure the disease. You're not going to cure the disease. And it's true, the medications, at first my husband took it, it helped. I would say I got 6 months out of some of those medications. At a certain point I realized it wasn't doing anything and I stopped it. But there are other medications to keep you happy, medications to help you sleep, medications to keep you calm. And if the person that you love looks calm and peaceful, you will be calm and peaceful. So I feel it's very, very important to find out what the person has and which medication works best. And each person and each diagnosis is very, very different. I also feel, on a different note, that it's very, very important to always be one step ahead of the game, meaning that at first, when my husband was able to be on his own in the house, and I had people checking up on him, I knew there would come a time when it would be dangerous and he would be wandering and I would, need more help. So don't wait until you're completely overwhelmed to look into the options of Medicaid. The law changed a few years ago. You don't even have to be 65. If you have a catastrophic illness, then you're entitled to get Medicaid. And that means that you can get, it's a big fight, but you will get aides to help you. And even though it's very difficult and you have to go through a lot of people until you find someone, if you keep at it, you will find someone that will love the person you love, not as much as you, but enough to be really, really kind. Sometimes you have to go through a lot until you get to that person. You're so disgusted, you're so overwhelmed, you don't know how you're going to get to work, and you don't know this and that. It's worth it, because once you find that person who's that angel, your entire life changes. I remember initially saying to one of my relatives, forget it, I'm quitting my job, I'm going to stay home and take care of my husband. And he said, no, you're not. You're going to have a breakdown. Are you crazy? You're going to be 24/7, this is what you're going to do? And I realized, he's right. Your life doesn't end. You can be there for the person, you can be on top of things, but you can't do this alone. You need a lot of support. Not telling people and hiding things just makes your life miserable. First of all, everybody thinks that person's nuts. Anyway, you're not hiding anything. People used to come into the house and, make comments to my husband, and he would feel humiliated because he didn't realize that he asked the same question 10 times, or he's shadowing me. There's a certain period of time where he was afraid, and everywhere I went, he went, that type of thing. Here was a man that was like, I need to make an appointment to get an hour. Now, if I'm here, he's here. It gets very difficult, and you need to give yourself a break. So I feel it's very important to get the right kind of help, and to get the right diagnosis, and to get the right medications. Want to stick anything in?
No,
Oh, okay. I also feel that there are ways you can help the person in the earlier stages, and you can keep their dignity. Dignity is the thing. I followed somebody by the name of Richard Taylor. He wasn't Jewish. It was a man who was a very classy psychologist or psychiatrist, and he himself got sick, and he had Alzheimer's. And he decided that he was going to talk to people and tell them, as suffering himself from Alzheimer's, what you could do to make my life better. And I found him so interesting. He said, my whole life I wore a 3-piece suit. Don't tell me to put on a pair of jogging pants because it's easier for you to change a person. I don't want to wear elastic. Some people don't care, it's fine. But you need to know the person. You try to keep the person the way the person was. If somebody loved a particular thing, my husband loved to learn, every day he would have a Tehillim in front of him. He would have a Gemara in front of him. These were the things that kept him calm. You know what the person did and what was important to the person. You keep those things important to the person, and you will keep that person happy. You also need to make yourself happy, and trust me, I know I look put together, blah, blah, blah. I have spent many, many hours crying myself to sleep, burying myself underneath my pillow, and everything that all of us do when we take care of somebody that we love that has dementia. It is the most heartbreaking, difficult thing that I could think of. I mean, the only other thing I could think of is Lou Gehrig's. That is vicious. It's a situation that is so painful because it just goes on and on and on, and it drains you. So you need to do everything you can to take care of yourself. So aside from getting great help and having my kids very, very involved with my husband, there was a period of time where I just couldn't stop crying, crying. Every time you saw me, my son only lives a few blocks away, he goes, Ma, enough. We're losing our father. I don't want to lose you. I can't take it anymore. He goes, I know, I'm the mean one. I'm telling you, I have 8 kids. He said, I'm the oldest, and everybody feels the same way. No one has the guts to tell you. So could you please get it together? I'm like, oh my God, like, how am I getting it together? I'm crying, and I realized I need to get it together. I went to speak to somebody. I took an antidepressant, which my whole life I swore I'd never, ever. And anything you have to do to make yourself happy, and believe me, I've tried a lot of weird things over the years. Whatever works. Whatever works. You cannot be only taking care of that person day and night. You cannot. Whether, you have friends, you start to hate everybody because they have no clue what your life is like. It's true, but you have to get past it and tell yourself that if you don't reach out to people, they don't know how to deal with you. People are uncomfortable. How many times do you see someone and they're crossing the other way? They don't want to see you with that person because they don't know what to say. It's human nature. People are uncomfortable with it because we're all scared of it. That's why. And it's one of the most frightening diseases. So you can't get mad. You just have to talk to people and explain to people. I once had a man tell me that he stopped socializing. His wife had what Dr. Salamon described, frontal temporal lobe dementia. It's very difficult. The temporal lobe is the part of the brain that affects judgment. So she became really annoying. And he said that her friends and all the people they knew started saying, like, you can come out with us, but keep her home. And he was like, forget it. I'm never going out with these people. Yes, there are people like that, but there are people that are exactly the opposite, that do everything and anything they can, if only you let them. Sometimes you close people off. It's not always that everybody's mean. Sometimes we get angry and we don't explain what we need. You need to tell your neighbors how they can help you. I write, it's therapeutic for me, and I remember once I wrote a whole article how you could do little things, leave a cake by somebody, do this, do that, and one of my cousins said to me, Hennie, the article came out, watch out, you're going to be bombarded on Friday. I'm like, yeah, right. He was right. I couldn't believe it. Everybody cookies and cakes, and yeah, if you ask, most people are good. They want to help you. They don't know how to help you. If you shut yourself off in your own depression and don't reach out to other people, no one can help you. So you need to help yourself. Helping yourself, whether it's medication, talking to someone, leaving and getting some sort of respite, and definitely getting help through Medicaid so that you have good aides helping you out. So that's my message, and I will hand over the floor. Oh, Richard Taylor. His name is Richard Taylor. Yeah.
Just very briefly, Mr. Gelman is going to speak for 2 minutes on hydrocephalus.
So hydrocephalus, as Dr. Salamon had said, is essentially it's water on the brain in the most lay terms possible. I'll try to keep it simple. To date, hydrocephalus is, as Dr. Salamon said, seemingly the only reversible cause for dementia. That is, though, to say that that's only when it's caught early. The three keys, the three clinical presentations, as it were, of hydrocephalus in the elderly population would be gait change, would be urinary incontinence, or dementia. Now, the treatment for hydrocephalus is what's called a VP shunt. It's an implanted device, goes into the head with there's a catheter that comes from the head down to the abdomen. It drains the excess cerebral spinal fluid, which would diminish the size of the ventricles, which hopefully, if caught early enough, will have the ability to reverse the dementia in the senior citizen population. As stated previously, since there are so many various possibilities of how somebody can get dementia, or is it Alzheimer's? Is it hydrocephalus? Is it Lewy body dementia? There's so many different possibilities. There is, unfortunately, to date, no definitive testing that can be performed to say with 100% certainty it absolutely is hydrocephalus. They have seen success with doing what's called an excess volume lumbar puncture, where they remove excessive amounts of cerebral spinal fluid, which will decrease the amount of cerebral spinal fluid around the cranium, which hopefully would mitigate the damage. And then if they see a reversal at that point, the doctors at that point will weigh the options of should a shunt be implanted or not. Even if, just a word of caution, even if the patient does present with hydrocephalus and is in fact,
show you water on the face?
Sometimes. Sometimes it does, sometimes it doesn't. Everybody has water on the brain.
I'm saying, but I would not say someone's brain be a little bit more, like when they talk about children being born with water in the brain, they have a larger head.
So in infants, it's vastly different than in the geriatric community, because for a host of different reasons, too brief time to get into it, but there is no, it can in fact present via an MRI, but again, that's not 100% conclusive. The doctors will, once the diagnosis of hydrocephalus is in fact pronounced, as it were, the doctor will then have to weigh the option of, do you want to put this senior citizen, do you want to put the elderly patient through a brain surgery, essentially, because that is the cure, as it were. It's not really a cure, it's a treatment option. As Dr. Salamon said, you're not reversing the dementia definitively, you're trying to slow the progression of it. If a patient is diagnosed with hydrocephalus and the doctor does decide to do the shunt, does not mean that the patient will not progress to having, in fact, Alzheimer's or other forms of dementia. This is just a possibility with the lumbar puncture. Like I said, with the lumbar puncture, as the fluid decreases, the hope is that the gait would change enough to give you that definitive diagnosis of hydrocephalus. Once you do have it, there is a patient that I'm actually working with extensively. One of the treatments that they have is they go for repeated lumbar punctures. I don't recommend it per se. I don't necessarily say it's not the right course of treatment. You have to consult your physicians. I did leave pamphlets over here for anybody that would want, with information about MPH. Thank you. Any questions?
Okay. I wanted to thank the presenters for coming today and sharing insight with us. Just want to remind you there are vendors upstairs who probably have a lot of services to provide you, so please visit and enjoy the rest of the day.